We're going to move pretty quickly or you won't be able to see much. I'm sorry. So this is a boy with a type of spondyloepiphyseal dysplasia. He had had 2 previous tibial Ilizarov corrections, 2 on both legs, and both recurred very quickly after the realignment. And you can see that he has significant genu-valgum with proximal tibial recurvatum, worse on the right than the left. Anyone have any suggestions as to why this might have recurred? Doing bilateral, gradual, upper tibial? They weren't bad. I mean, I didn't do them, but they were okay. Why would this have failed? So what do you see in the hips? That was maximum abduction there. So if you have no abduction and a various orientation of your femur, my theory is that you get rapid recurrence, but not always. But so if the person who had done the tibial realignment had got the legs straight, they would have had to walk with their legs crossed. So you have to address multiple levels, right? You have to think what's going on at the hip, the knees, and the ankles. So just a small learning from my perspective. So we did the hips. We realigned both tibias, and here was the result. But you have to follow these kids long term, as Dr. Cho showed us in several cases there. Drifted into valgus, used growth modulation, straightened them out, and with a good long-term result.
And I'm going to present another case with recurrence. Is pseudoachondroplasia, very typical X-ray. And she began to develop this windswept deformity, and it became severe. So I corrected the left limb first using the acute correction by osteotomy, internal fixation femur, external fixation tibia. It looks very nice in the beginning, but only 6 months later it recurred. Genu-valgum recurred so severely.
So ask them why.
Yeah.
Why did it recur? Are you a bad surgeon?
It's a bad patient. So I looked at the distal tibia, the distal femur fasciitis. There's a defect over here. So after the plate was removed, then I took the MRI and bone scan. So I found that there's a cartilage became so huge, and they don't have any fascial activity by bone scan. So that's why it recurred so rapidly. And also, this part is, that's typical pseudoachondroplasia finding, but cartilage is redundant like this, but this part is more redundant, and they don't have any fascial activity. So that's the reason. That is the biological reason. I mean, I didn't touch it at all during my osteotomy, so I believe that is a primary defect, and that may be the biological reason for recurrence. But Dr. Mackenzie's case may be the mechanical reason of the recurrence. And then it is very evident the deformity will aggravate, and 3 years later she develops so severe deformity like this. And then look at this severe valgus deformity, so I had to correct it by external fixator, but because it is a very short femur, there's no space for the half pin from the lateral, so I had to insert the half pin from the medial side and lengthen it because it is much shorter than the right femur, and lengthened, and deformity correction was done. And finally, we obtained this alignment. Now we have to correct the proximal tibia and also the spine. So it is a long way to go.
This is just a quick case to show you what not to do. So this was not I received this boy and then fixed him after this, but this was, how he presented to the initial surgeon at age 7 with a significant thoracolumbar kyphosis and some signs and symptoms of spinal stenosis. So, what's the treatment? You got it. Are you happy with that? Why not? It's not corrected, and it's a pretty short fusion, isn't it? So what's going to happen here? Exactly. So you're going to get junctional kyphosis, but look what happened. Junctional kyphosis, fracture of the instrumentation, pseudoarthrosis, progressive deformity, and here he is at age 17 with a huge problem. I went on to fix him successfully, but big problem. Shall I continue with Morchio, or should we do the other one? Are you guys okay? Should we? How's the time? We're okay? All right, sorry, we're rushing along. This is a patient of mine with Morchio syndrome. I did a Brooks and a transarticular screw for upper cervical instability. And you can see that the upper cervical segments on that follow-up MRI are fine, but the child has developed instability between the second and third cervical segments with some cord compression. So how are you going to treat it? Extend it distally. Okay, so do you want to do any studies preoperatively? Flexion extension, which I got there. Yeah, so I did a CT because I was trying to look, I was thinking about using lateral mass screws, and I wanted to see if I had enough room to get them in. And so this was a CT. I planned to remove those transarticular screws using a pedicle screw system, not a pedicle screw system, but a standard upper cervical instrumentation system. What's the problem here? What didn't I notice? What's wrong with that screw? Very, very close to the vertebral artery. You were all smarter than I was. So when I took that screw out, I'm not kidding, it's like the blood hit the ceiling. I've never seen anything like it. If anyone, has anyone here seen a vertebral artery? Yeah, it is torrential. And putting a screw back in didn't help. And luckily we were able to calm the bleeding down. It was very, very difficult. And you can see from this post-op MRA, that's the other side, and you can see that vertebral is cut off right here. You know, remember that supplies the basilar system, and if it is a dominant vertebral, you will have a problem with the posterior brain. So I was very lucky. And so we ended up doing an onlay fusion, putting the child in a halo, and look at the fusion we got. Too much. It just extended distally, as kids do sometimes.
After 5-10 years, is he going to extend progress?
He may, it's a she, but she hasn't to this point, as you can see, and that's quite a recent follow-up there. She's in university now.
But that junctional zone is the most unstable area.
I completely agree. Yeah, we have to watch it.
So this is another case, adult with 35 years old Smith-McCord dysplasia. He's very short, and he cannot work. He's just a therapeutic ambulator because of a severe knee deformity. But what kind of knee deformity it is? If you look at the lateral side, this is a patella. So he has severe genovalgal. It's not a flexion contracture, it's a genovalgal. And the hip joint is totally dislocated on the right side, there is no femoral head. So we diagnosed it by next generation sequencing, that Smith-McCurry dysplasia. And then how to correct this genu valgum. So I performed the acute correction on the femur. It was possible because distal femur, we can do it safely and fixed with the external fixator. It was very convenient for me. And then for the proximal tibia, for fear of the neurovascular compromise, I performed the gradual correction using external fixator and gradually corrected and achieved the correction nicely. So after the completion of the correction of the left limb, we are going to do the right limb correction. But the patient is a 35-year-old smart man. He decided not to have operation on the right side if you apply the external fixator. So I had to use internal fixator on the right side. I wonder whether is it possible to correct the correction of this kind of deformity using internal fixator, but I managed to fix it using this funny looking the plate. There was no plate available to contour like this, but I could translate the distal fragment this way and then fix it sufficiently. And also for the proximal tibia, I released the common peroneal lobe completely and then corrected acutely using osteotomy. And then finally we could achieve this kind of correction. And now he can work at home. So he became a household ambulator. Then I am concerned he may complain hip pain sooner or later. But anyway, so that is the example that external fixator is very inconvenient for the patients. He would not have that kind of operation again.
There was significant femoral retroversion on that as well.
But actually, because there's no, he mentioned that is there any retroversion of femoral head, but...
No, retroversion distally. There's external rotation.
Yeah, but I think that the hip is moving around in any way, so that is the only way he can stand up in this position. So after correction of the angular deformity, I didn't correct the rotational deformity. After correction of the coronal plane deformity, then he can stand up in that position.
We still have 5 minutes, so we can do one more.
Oh boy, okay. This is just a really bad example here. And I just want to show you how severe it can be. So this boy was 16 years old when I met him. He had achondroplasia. He had severe symptoms of spinal stenosis. He could only walk a short distance before he developed neurogenic claudication, and he had bladder abnormalities, and he had burning sensations in his lower extremities. And he had multiple procedures in the past, and they had included initially an attempt at a decompression, and they lost the signals and they couldn't put any instrumentation in. Then they tried an anterior and a posterior fusion and lost the potentials again, took out all the instrumentation, and then tried an anterior fusion with the strut, and you can see it failed. So anyone have any suggestions as to treatment of this? This is a severe thoracolumbar kyphosis after multiple anterior and posterior approaches with severe symptomatic spinal stenosis. VSO? Multiple, so do a VCR or an anterior resection. Anterior would be pretty tough here. You'd be working in a very small cavity. But I think this boy clearly needed some management. This is an example of a very, very tough procedure. I did a 2-level VCR, and we straightened him out very slowly, and he was neuro intact and went on to into a excellent alignment and good function. But I think the most important thing here is that you need to achieve appropriate alignment. One of the biggest things in achondroplasia is a lot of adults who had spinal surgery walk like this. They lost all their mobility. You have to get them mobility.
Okay.
Does anyone have any questions about that?
In achondroplasia, when it grows up to a marriageable age, he says, I want to get married. And nobody else is willing to give the gun to get married to this achondroplasia. And can achondroplasia get married to achondroplasia?
So the question is, can a male person with achondroplasia marry a female with achondroplasia? Yes, I have many families with 2 achons as parents. So what's the genetic result of that? It's a dominant, right? So, yeah, go ahead. You answer.
So if the 2 achon get married, they can have the 3 possibility: normal baby, or achon baby who has 2 mutations. They have very severe the phenotype, like a thanatophoric dysplasia, so they usually cannot survive. So there are 3 possibilities.
So you can have a tall kid, a short kid, or a dead kid.
Would you allow them to get married?
Of course.
Yeah.
It's their decision, not yours.
Thank you, Dr. Mackenzie. Thanks, everyone.